Hello, everyone, and welcome to Session 1A in our Facilitating Access track. This is engaging clients in clinical services for serious mental illness and substance use disorder. My name is Kristen King, and I'll be your producer for this session. I do want to let you know that this event is being recorded. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. I'm going to open up Sherry Downing's line. Sherry Downing is our moderator for this session. And Sherry, I'm going to hand it over to you to take it away.
Thanks, Kristen. So welcome, everyone. We are so delighted that you chose this session. I am very excited about this topic, improving access for people experiencing homelessness and who have serious mental illnesses or substance use disorders or co-occurring disorders. So we are delighted you're here. I would be particularly interested in a public chat if you could type in where you're coming in from so we can get a sense of that. I see Patricia D. coming in from Hawaii, so welcome. We've got Wenatchee, Washington, and Racine, Wisconsin, and North Carolina, and now it's going way too fast for me to keep up with. So thank you. I think what this is telling me is that there is a huge need in the field to be able to help our clients access the kinds of services that we're going to be talking about today. We have brought to you two of the best speakers that we could find in the field to talk about this issue. The first one is Jack Tsai. He is a PhD associate professor of psychiatry at Yale University School of Medicine and research director for the Department of Veterans Affairs National Center on Homelessness. Dr. Tsai has received federally funded grants and published more than 150 peer-reviewed articles on topics related to homelessness, severe mental illness, trauma, and health disparities. He has been a grant reviewer for the VA, the Patient-Centered Outcomes Research Institute, the Social Security Administration, and several foundations. In addition to those roles, Dr. Tsai is the director of the Division of Mental Health Services Research at Yale and holds leadership positions in the American Psychological Association and the American Public Health Association. And he serves as editor-in-chief of the Journal of Social Research. He teaches and supervises interns, residents, fellows in the VA, Yale, and surrounding universities. So we're delighted to have you join us, Jack. We also will be hearing from Raul Almazar. He is an MA and an RN and a subject matter expert with the Homeless and Housing Resource Network and the National Association of State Mental Health Program Directors. Mr. Almazar has many years of experience as a direct care provider, administrator, organizational and clinical consultant, trainer, and speaker. Prior to becoming a full-time consultant in 2009, he served as Deputy Director for the State of Illinois Division of Mental Health, where he was charged with facilitating an organizational culture shift in all 10 state-operated facilities toward person-centered, trauma-informed, recovery-promoting, non-coercive treatment settings. He is a senior public policy advisor at the National Association of State Mental Health Program Directors, often known as NASHPD, Center for Innovations in Behavioral Health Policy and Practice, and served as senior consultant to SAMHSA's National Center for Trauma-Informed Care and promoting alternatives to seclusion and restraints through trauma-informed practices. So with that, I'm going to move us to the agenda for today. I apologize. First, we'll hear from Dr. Tsai, who will discuss facilitating access to care for clients with severe mental illness and substance use disorders. And then we'll hear from Raul Almazar about engagement strategies in the community, lessons from the field. We'll have some time for question and answers, so please put your questions in the question box, and we will get to as many of them as we can and then we'll move on to closing. What we hope you take away from this today is some discussion about the challenges that occur during the engagement process. We know that many of you have a great deal of information about that coming into this room, so we hope that you will share some of your expertise and experience in the public chat. We'll introduce some of the research on techniques used in engagement, discuss the role of technology in engagement, and list some of the potential advantages and limitations of mobile interventions. So with that, I am going to ask you to put in the chat box just what are you hoping to get out of this session? What will make this time well spent for you? And with that, I am handing it over to Jack Tsai. Welcome, Jack.
Thanks, Sherry. Hi, everybody. It's great to be part of this virtual summit. I'm very excited about it. So on the topic of facilitating access, I'm going to touch on 3 different areas: building relationships with clients, integrated models of care, and technology-assisted approaches to help facilitate access. So in thinking about building rapport, there's actually decades of psychotherapy research starting in the 1970s, 1980s, and it's continued till now, looking at what are the most effective psychotherapy approaches. So there's been a lot of clinical trials comparing different types of psychotherapy approaches, and what all these studies have concluded is what's called the Dodo bird verdict. If you remember Alice in Wonderland, there was a dodo bird that exclaimed, "Everybody has won and all must have prizes." So what that verdict means is basically it wasn't any particular psychotherapy approach that was most effective. It was really the common factors across the therapy approaches that was effective, namely therapeutic alliance, developing empathy with your clients. So in essence, a lot of these psychotherapies are effective not because of the particular approach, but because of the relationship that clinicians had with their clients. So we sought to look at this among chronically homeless adults to look at what is the importance of therapeutic alliance. So we did a study of about 750 homeless adults across 11 sites, and then we followed them for a year, and we basically found that therapeutic alliance, starting at 3 months, stayed pretty much stable throughout the year. So the relationship you have with your client at 3 months pretty much stays the same over time. We also found that there weren't really any socio-demographic characteristics associated with therapeutic alliance. So race and age of clients and therapists and clinicians didn't matter that much. Interestingly, we found that there wasn't much association between therapeutic alliance and housing, employment, mental health, and substance abuse outcomes over time. But there were associations with subjective higher quality of life, perceived social support, and more outpatient service use. So in essence, therapeutic alliance is really important for some things, but not for everything. So I think the important point there we found is that therapeutic alliance is necessary, but it's not sufficient for outcomes in housing, employment, mental health, and sometimes practical assistance and helping facilitate access to material resources for clients, such as helping them with income and housing, can be more important than the relationship with the client. And so I think it's important to sometimes differentiate between initial engagement and sustained engagement. So just as a case example, we have John, who's not enrolled in care, very difficult to engage, and needs a referral to care. He has expressed he wants to find a job. He has employment needs, but not particularly interested in clinical services, doesn't want medications. So I would say John is kind of in the initial engagement stage. And so you would need certain engagement strategies for John that would be different from Mary. So in Mary's case, she's already enrolled in care, but she has trouble keeping appointments because she has a job and she has children. And so that's that's the barrier to her engagement. So in the case of Mary, she needs strategies to help her with sustained engagement. So these are just case examples to illustrate the different strategies you need depending on the person's stage in care. So I just listed a few engagement strategies there, but for example, someone in the initial engagement stage, you might want to be client-focused and strength-based. It's often helpful to ask for collateral contacts up front, collateral contacts being family and friends that know where the person is, and that could help facilitate contact with the person if it's hard to reach the person. And somebody in the sustained engagement stage, it'd be important to assess barriers to care. Oftentimes in vivo community visits help, so meeting the clients where they are instead of having them come to meet you in the office. And also it's important to incorporate shared decision making and flexibility with the client to again, meet them where they are. I think in thinking about engagement, we should anticipate challenges. If I can invoke the yin-yang philosophy there, it's really a balance between resources and obstacles. The more resources someone may need, there may be more obstacles, and increasingly as more obstacles arise, it'd be hard for them to access resources. So I think there's internal and external barriers we have to consider. In terms of internal barriers, there's multi-morbidity and disability. We've really kind of moved away from comorbidity because in reality, a lot of people have more than two conditions. So dealing with the multi-morbidity it can be a challenge, and this can take this can be in the form of cognitive deficits, memory and recall problems, physical disabilities, which certainly can impact transportation and ability to physically access healthcare facilities. And then, of course, mental health symptoms and active substance abuse symptoms can affect comprehension and follow-through. We also have to recognize there's distrust of professionals and systems among some clients, especially those who've had bad experiences with healthcare providers. And research has shown there's a greater distrust among racial ethnic minority groups. There's a long history there of abuses in the system. And we also know from research that men are generally more reluctant to seek care, so that's important to keep in mind. And of course, our healthcare system is very complex to navigate, so helping our clients navigate the system and make the connections is important. And this is just a diagram to illustrate the various access points which may be difficult to access, and there's very different systems, and all of these can be characterized as social determinants of health. So, for example, if somebody is filing for disability and employment, they would need access to Social Security. They may have issues with their housing, whether it's Section 8 or it's private rental unit, where they might have landlord disputes or facing evictions. Again, transportation through the DMV or public transportation. Of course, there's the family court and the criminal justice court system as well. So there's various techniques. I'm not going to be able to go through all of them in detail, but I wanted to just mention some of them. Of course, we know it's important to be very client-centered focused, so meeting clients where they are. We've done studies basically assessing needs of homeless clients, and we found that there's surprising things. For example, dental needs is often a top priority of homeless clients, and as a clinical provider, you might not think of that, but so often it's important to assess the client on what their needs are. Sometimes it's helpful to have low threshold activities, low barriers to entry. This could be thought of almost like the foot in the door technique that sales people use. So you offer something that's pretty easy, like recreational, educational group activities, brief intakes, and that way it may be an entryway for more intensive care later on. Harm reduction obviously is an important philosophy. Prochaska's stages of change. This is understanding that different clients are at different stages of when they're ready to make changes, behavioral changes, and meeting them where their stage is at and tailoring the intervention toward that stage. And of course, harm reduction is focusing on reducing risky behaviors and negative consequences. Related to harm reduction is motivational interviewing, and this is a evidence-based technique. I just listed two strategies there, which is explore ambivalence and roll with resistance, which I think both are very important when dealing with clients that have various life challenges, and being able to roll with their resistance when they're resistant. And again, similar to the therapeutic alliance, it's important to establish trust. Gentle persistence, I think follow up and follow through. I think it's also important to be clear with clients what you can help with and what you can't, and not over-promising when you shouldn't. Okay, so let me talk a little bit about some integrated models of care. I think integrated models of care are really important because they're client-centered, and oftentimes they can help clients access address multiple needs at the same time, and with one access point. So the first one is the Homeless Patient Aligned Care Teams. It's abbreviated HPACT, which was developed by the VA, and there are now 60 active HPACs throughout the country, and they're basically integrated primary care providers in homeless programs. So they're co-located, and clients can often come in to receive homeless services and primary care, often on the same day, and so it serves basically as a one-stop shop for clients. And clients can also walk in and be provided a range of services and benefits and practical assistance. So integrated dual disorders treatment is a evidence-based treatment, and it's basically integrating mental health and substance abuse treatment. As recent as the late 90s and early 2000s, mental illness and substance abuse were treated separately by different clinicians in parallel systems. But we know now that it often makes a lot of sense to integrate the two treatments, and there's a synergy that develops. That's the sum, where the sum is stronger than the whole is stronger than the sum of its parts. So clients can participate in one program that provides treatment for severe mental illness and substance abuse disorders, and providers are trained in both. And the substance abuse treatment is often tailored to clients with severe mental illness. So it's, for example, focusing on preventing anxiety rather than breaking denial, having a slower pace and a more long-term perspective, and also it's often in the community, so meeting clients where they are, and often other social services are provided at the same time. And of course, SAMHSA actually has some evidence-based toolkits on integrated dual disorders treatment, and they have fidelity scales as well. I encourage you to check that out. Okay, and the third integrated service model I want to talk about was medical-legal partnerships. So these are often called MLPs. They were developed in the 90s to combine the skills of medical professionals and lawyers to help patients. And they're basically legal clinics embedded in healthcare settings. And there's now hundreds of these MLPs throughout the country embedded in hospitals. And basically, the legal providers are responsible for helping patients with addressing their legal needs that may impede access or impede some way their recovery, their healthcare recovery. As part of a larger movement to address social determinants of health, it's recognizing that a lot of legal issues can impact health, especially civil legal issues. So often these MLPs address civil legal issues versus criminal justice issues. But there at the bottom, the abbreviation I-HELP is often used to characterize the different kinds of civil legal issues that these MLPs can address. For example, income supports and insurance, housing and utilities, for example, evictions, employment and education, legal status, like immigration status, personal and family stability, including child support, divorce. So just as some examples, I work closely with our medical legal partnership at our VA. Clients often have a revoked license, so they can't drive to the hospital or they can't drive to a job interview. And so these MLPs can help with helping the client obtain their license again. Unpaid child support taxes can cause a stress. Of course, finances can limit one's ability to access certain services. These medical legal partnerships also often help people with their disability benefits, appealing denials, helping people with their paperwork. And so we've done a study of medical legal partnerships in the VA at 4 sites, and it was over a 2-year period. And we basically found that clients with severe mental illness that accessed these medical legal partnerships showed improvements in housing, income, and mental health over a year. Specifically, symptoms of hostility, paranoia, and anxiety decreased over time. So in essence, these medical legal partnerships, they address legal issues, but they were actually also resulting in improved mental health. And that study is published in Health Affairs. Okay, well, let me move on to talking a little bit about the role of technology, because the role of technology can really help facilitate access to care for our clients. Several studies have shown that low-income, vulnerable clients, many of them own mobile phones. They have access to computers. They use the internet. They may not have computers in their homes, but they are able to access it through public libraries and things like that. And so that opens up a lot of avenues to engage and reach these folks. For example, there's some interesting things around text messages. There's been various studies using text reminders to help clients increase their clinic attendance, to attend appointments, and also just to maintain engagement, some of that sustained engagement I was referring to earlier. And of course, text messages is simple, efficient, low cost, but I should note that it's important to think about about setting boundaries and maintaining privacy standards, especially with text messages. Besides text messages, there's personal electronic health records. So a lot of hospitals now have encouraged clients to access their own records, and they allow clients to edit or even request changes to their electronic health records. I think this is important for engagement and also helping facilitate some of the trust, because it encourages transparency, and it allows clients to have control of their care. So just some potential barriers to think about. Some of older clients may have difficulties accessing new technologies. I know we've done some computer-based interventions, and we've had to teach some of our clients how to use computers. Though that being said, I think a lot of our clients are very interested in learning. And then beyond that, there's also some physical impairments like vision and other mobile impairments that may affect access to technology. So that's important to think about. Of course, smartphones also have massive potential, although studies have shown that we have all these really innovative smartphone apps, but uptake by clinics and clients seems still pretty low. Although it seems clients with schizophrenia, it is feasible to use smartphone apps to engage them, and when they do use them, they're pretty satisfied with them. And so there's been various efforts to gamify behavior change. make games out of them, make it somewhat of an entertainment aspect to it. And it can facilitate referral engagement with services. They can be used in kind of with individual clients and in groups as well. So I just showed three images of different kind of computer apps and smartphone apps that have been used. On the far left is one for sleep, and the middle one is a program called Represent, which I actually was involved in studying, basically teaching clients how to self-represent in court. And we found that in our study, we found that this app helped people feel more empowered in their lives, and also led to improve mental health outcomes because they were able to learn how to self-represent themselves and self-advocate. And then on the far right is a phone app that was developed by the VA called the Virtual Hope Box, and it's designed to help with depression. And you can personalize it where you can include your own family photos, you include your own music, you develop your own coping strategies, and there's also games that you may need to help distract you when you're feeling depressed or you have suicidal ideation. So it's neat in that you can kind of tailor it to your own needs and personalize it. So this table just helps us think about some of the pros and cons of technology. Obviously, on the pro side, it can increase access to psychosocial interventions. People can do it in their homes and also on a regular basis. In terms of data, it can help us kind of monitor real-time data and continuously. And as I mentioned with the Virtual Hope Box, you can personalize it and there's flexibility in how it's administered. In terms of the cons, it can diminish therapeutic alliance because you may be interacting less with a clinician, which, as we talked about, is important. It can be costly. There's privacy concerns and confidentiality concerns to be considered. And then, of course, if folks have cognitive impairments or physical disabilities, they may have more difficulty accessing some of these technologies. So beyond kind of personal technology tools that can be used, technology can really also be used to change public perceptions and affect outreach kind of at a macro level. So, for example, social media, and I just highlight there on the left two programs, On Track New York and Mind Map, which are both programs that are designed to outreach to folks with early episode psychosis. And I think that's a good example because some of these young adults with early episode psychosis, they've haven't been in contact with the mental health system before, and they're just developing a severe mental illness, and so you have to think of creative ways to outreach to them. And so these programs, they offer video testimonials, which can help reduce stigma. They have social media accounts that provide regular updates and share new content. They also have platforms for peer support and social support. And also, it's a way to showcase therapies and innovative treatments. I've seen some interesting ones on electroconvulsive therapy. So I think those are good examples of how social media can be used and leveraged to help outreach and facilitate access to care. And so these are my references if you want to read more about some of the studies and resources I mentioned. I'm happy to take your questions after. But let me pass it over now to Raul for his presentation.
Thank you, Jack. Good afternoon. Thank you for having me, and I just want to do a forewarning. I'm actually sitting at an airport, and so there may be a little background noise, and we will try to keep that to a minimum. I'm thrilled to be part of this, and I thought as we were preparing for this session, Jack had so much great information and research and latest technologies that I thought I will focus more on the engagement at what I'm seeing out there and some examples of engagement. And part of this is also a lot of my work really is out in the community and being able to see what is happening at the community level. We just finished filming a documentary that will include snippets to go into a curriculum of about crisis services. And one of the interesting things is as we're looking at crisis services, how are they used, who are the people coming in, it was inevitable that we end up on the homeless side and understanding crisis services, relationship to homeless services, relationship to engagement, and all of that. So if we can put up the first slide, and really I want to start with community, because as I said, that's a lot of my work, but it's the connections, and in terms of engagement, what I have found, for example, is the more siloed services are, the more disengaged people are. So that's one of the things we find, and it has a significant impact on what we're looking for engagement. So for example, we were doing a focus group in a city, and someone said, I am in a prison reentry program, I am doing well, I've got a job, and it was discovered that he was late in his child payments. So they started garnishing his wages, so he lost his apartment, lost his job, could not afford being able to live outside. So it's really the importance of the connections of our services. In fact, talk about connections. In fact, one of the questions I saw on the list earlier is funding. I do know in terms of connections, I have been in large cities that have a ton of money for housing that they cannot spend because of the not in my backyard phenomenon. And so the political willpower is not harnessed to get for people to be able to do all of that. So anyway, the point in my wanting to start with community is the importance of those connections, and also the importance of understanding community. So for example, we do know, and I have seen and spent quite a bit of time in the homeless community. And so there are social structures in the homeless community that people do look for. We have the shelter community. How many people have we found housing that will come back to the shelter because that is their community? So it's the importance really on being able to look at the intersection of different services, but also what types of connections and community we offer, that we may see people as appearing to be resistant or not wanting to engage, when in fact a lot of times they don't want to leave their community. So I think that's an important piece that I have seen out there. We have now the other piece is the social ecological model, which is, I think, what Jack has already referred to, that if we think about engaging people with mental illness, substance use disorders, homelessness, these are all small pieces of this person as an individual and this person's relationship to their community, to their social system, and so to really create understanding and looking at the people we're trying to engage in the context of a social ecological model. next slide, please. Okay, so I just talked about the social ecological model. So some of the things that, I thought I'll start with some examples of community efforts I have seen. If we have the next slide, please. Okay, so we've already talked about connection. So one of the things that I think has taught me as I'm doing a lot of this work out in the field is to, as we develop all of these strategies and wonderful innovations in helping engage people, is to really also be very, as Jack said, client-centered, because the inability or refusal to engage comes from many different places. I'll give you one example of this. I was in a transitional and housing program. Wonderful, beautiful, incredible, very flexible. One of the things that the program only asks, and it's mostly with the mothers with children, is that once a week they all come for dinner. They want to build community. They want the women to build, to develop interactions, and they even have people who come and will babysit the children so that the mothers can talk freely and be able to spend time at dinner. And they have very low attendance, and it's frustrating because they've done everything. They don't have many high requirements. This is one of the few requirements they're asking people. They tried changing the days. They tried changing who prepares the food, and all of that. It's still low attendance. Until they dug deeper and realized that many of the mothers in their transient housing are coming out of reunification. And so if I just got my child back from reunification, separating me from my child for other people to watch my child, and fear of what my child will say to that person, and get back, and the likelihood of the child being taken away from me is too high of a fear. That's why people are not showing up for the dinners. No, it's really what I really learned a lot in terms of the engagement is that to really spend time to also look at there are different reasons why people are not engaging. So from that, I thought one of the things, there are two programs that I thought I will present today that I wanted to just give you guys an overview. So the first program is the Baltimore Homeless Outreach Team. This is, let me see the next slide, please. This is coming out of the Baltimore Police Department. These are 3 detectives whose full-time work is homeless outreach. And I thought I will talk a little bit about some of their strategies, and I've been out riding around with them and going to the communities and give you some ideas of some of the ways in which they engage. So one of the first things that the police officers taught me as they are doing this work is that people will participate in programs when they are ready. So one of the things that I have seen the police officers do day in and day out is hand out cards and basically say, when you're ready, I have housing, I have rehab, I can connect you to all of the services. You just need to let me know when you're ready. The other reason why the police officers really have done a fabulous job of practicing that is because it was how they are able to gain the trust of the homeless community. That these are not people coming in telling them what to do. These are people who are ready to give them resources And so one of the things that, for example, that the team does is that they do know the names of almost every homeless person in the city of Baltimore. They call them by their name. They know which corner they stay at. They know the frequency by which people move. I mean, they know a lot of things, and it's really fascinating to see around the engagement. So, you know, we stop and talk to one guy that, you know, he has his own island, and he said, you know, these officers took me 2 months before I would sit and really talk to these officers. Took me that long for me to be able to trust them. The other thing that I think is significant in the work that you do, again, let's talking about engagement. If there is an arrest that needs to be made in the homeless population, or if there are things happening, the detectives who are part of the homeless outreach team do not do the arrest unless it's life and death, and they have not had that. They call other law enforcement to do the arrest because they do not want to fracture the relationships that they have developed, and it's really been very effective. Other things that they do that I think are really, as we know, as we talk about engaging people in services, one of the things they do is that they understand, especially for trying to get homeless people into housing, they have a lot of different priorities. So regularly and possibly every week, on Monday morning, they will bring a van to an area where the homeless population know that they can meet the officers, usually in Inner Harbor, and they take them to get IDs, birth certificates, and whatever else they need so that they can get employment or they can get benefits. So they just take them on the van. The beauty of it is that the police officers have clout. So they the programs that they go to get this are not as rigid with the police officers because they know what the police officers are doing. So it's really interesting. The other thing is that police officers of the homeless outreach team have relationships with different programs. So even if a shelter is full and they identify someone who's really needing assistance, the shelter programs would basically say, bring them over. We will find a place for them. So that there's the connections that are so well developed in all of this. Some other things that I can give you, one of the things that they do talk about in terms of engagement is really also encouraging our programs that we are trying to get people to come in and engage with, to really take stock of the policies of our programs that actually do keep people away. That it's not just people choosing or not choosing to engage in us, but we also have our own practices that really does not facilitate engagement. So again, I'll use the Baltimore homeless outreach team. We are out in the field. Young man, 24 years old, comes up, says, I hear you guys have a care package. We said, sure. Care package has water, lip balm, socks. And so we gave it to him, and the homeless outreach team asked him, how are you? Why are you homeless? You know, gave us his story. Basically addicted to, was in an accident, addicted to pain medication, eventually with heroin, and has been to 2 rehabs. And the police officer asked him, are you ready for rehab again? He said, yes, I am. Are you sure? Because we really want to help you. Yes, I am. Okay, I'm going to make a phone call, and we will get you in. Homeless outreach team leads, calls one of the treatment programs. Treatment programs has space. She goes back to the individual and asks him, did you use today? He said yes. Oh, well, the treatment program does not admit people who use the same day. So we'll have to see you tomorrow. We'll meet you here tomorrow morning to take you to the treatment program. Well, guess where that person was the next day? Nowhere to be found, right? And it's really beginning, it's really beginning to understand the policies that also prevent people from engaging with us. The next program that, let me see, that I want to talk a little bit about, and I can give you a lot more ideas if we have time on what else the homeless outreach team is doing. The other thing about the homeless outreach team is I do know we have sent the Baltimore Police homeless outreach team to Michigan, and they're developing that. I do know that there is one in Houston. So this is a practice that really has been picked up in a lot of the cities. The other thing that the police officers have said to us is they also know where people are stationed. So if there are crimes or things that occur, they have a relationship that they can come up to Christian and ask, hey, Christian, something went down here last night. What did you see? And they have a relationship, and they said it really helps them with patrolling because they really do have a relationship with the eyes and ears out there. The other thing that really I've seen them do is because they also know the homeless community and they are part of the homeless community. So we went into a small park where there were probably about 25 homeless people milling around, and they know there are some drugs being sold there, but they said, we know, but we have never seen being exchanged or really arrest, so they're really careful. However, there is a person that basically sits in that park and really is almost like the captain of the park. But one of the things the person pulled one of the detectives over and said, I want you to go 3 corners down. There is a young girl who I've never seen before who is panhandling in that corner. She is new, and you can tell that she is innocent, and she's going to get trafficked if you guys don't do anything about it. So they do watch out for each other. They do use their community connections to also keep each other safe. Okay, having said that, I think I have maybe 7 minutes to go to the next one. The next one, which is interestingly, is engagement through environmental design. And this came out of the Dolores Project here in Denver. And I thought it would be interesting to talk a little bit about also how our environment do either facilitate or does not help engagement. A little bit on the story for this. I was doing training with the Dolores Project, and it's a women's shelter in Denver. And unbeknownst to me, they are in the process of designing a brand new building for their shelter, and that they invited the architects to my training. And afterwards, the architects came up and said, my God, we had no clue what you just talked about clinically and how we need to understand that in terms of how we design programs. And they said, we are going back and we're going to do some redesign. So I thought I'll show you some pictures and just see how wonderful these people are in doing this. So one of the things, as a result of understanding the histories of the people that are in shelters, is they created what they said the key ideas that they are now using for design. If we could have the next slide. So Chad is the head of this design firm. And so Chad said, you know, when we are going to design, now we are looking for, we are designing for children, we are designing to promote connections, we are designing to promote passive and active safety, we're trying to design for joy, dignity, symbolic meaning, hope, grounding, and peace of mind. I mean, that's pretty darn amazing to all, to people to really hear people say, this is what we want our shelter to look like. They do that because they specialize in shelters, transitional, and supported housing design. So let's see the first picture. So this is the outside of the Dolores project, and what happened with the Dolores project is the women in the Dolores project made quilts. So in the old Dolores project, and even the new, when you walk in, you're going to see a lot of quilts. So one of the first things that the design team did was that, as part of their design, is they took the quilts, looked at the quilts, and they designed the building based on the quilts that the women in the shelter have developed and have made. So that's some of that artwork inspiration really comes from the quilts. Next slide. You can see now the challenge in that they and the reason why you saw in some of their principles, because this was a shelter attached to transitional housing, attached to permanent housing, so that they have very different needs. So therefore, this side you're seeing is the entrance to the shelter. There's a different entrance to different parts. So it's really, they really had to incorporate a lot of the people's experiences. So next slide, please. I'll just go through this pretty quickly. I'm running out of time. So this is the inside. So one of the things that they do know is that they have used a lot of glass for visibility, but they also made sure that there are a lot of corners that are that people feel secure. For example, one of the things that they had to redesign is they talked about, for many people, the fear of stairwells and what happens in stairwells. And so one of the things is they made sure that the stairwells have see-through doors so people can see what they're walking into in terms of the stairwells. Another wonderful piece that I have learned from them is they redesigned to make sure that in the hallways where at the housing side, that all of the doorways are staggered. And it really has to do, they said, with one of the worst things that can happen is when you open your door leaving your apartment, is you look directly into your neighbor's door across the hall, so that all the doors have to be staggered to prevent that trigger of just what you're going to find. So next slide, please. Let me see what else I put up for you guys. Okay, so dining room again, quilt. Next slide, please. Okay, so one of the things that is really wonderful about Denver, so this is a building that has just been donated to be converted to transitional housing. And next slide, please. And this is how they're planning to convert that housing. I want to point out something in this design that I think is really helping us go back to thinking about communities. On the right-hand side of this picture, you will see it's a three-story picture. There's, there's this, that's open stairway, the red structure in the middle. And to the right of that is a little structure, and the top of that is going to be an atrium. And that atrium is going to be a smoking area. And so one of the things, as they're designing this, one of the things that they are looking at is not planting a tree in front and having that atrium have a better visibility of the front door, and really making those smokers be like our elders who would sit in their porch watching the front door to make sure people are safe. So that's really the way they're going to build some of that community work, and they're going to lower the fences as well so that there will be a lot more of watching because of the presence of children. They want, especially some of the older clients in transitional housing, to have places where they can sit like they're rocking in their front porch. Next slide, please. These are all in Denver. This is the inside of that housing program. As you see, that one of the things that they really do is that they want communal space, but they also want private spaces where people can be alone. And I think that last slide. That's it. I thank you, Jack, and I thank you for the privilege of presenting, and I'm turning it back to Sherry.
A co-moderator has joined the conference.
Thank you, Raul, and thank you, Jack. This was really wonderful information. And we have lots of questions coming in from the audience, and so I'm just going to start right out with one that we've gotten several times, which is, how do you find medical legal partnerships? People are asking about finding medical legal partnerships near them, and are they in Oregon, and how do I know, and where do I look? So Jack, could you talk a little bit about that?
Yeah, sorry, I forgot to mention that there's a National Center for Medical Legal Partnership. It's based in D.C. With George Washington University, but they have a website and where they're tracking all the medical legal partnerships in the country. So if you go on their website and you put in your state, you'll find a list of all the existing medical legal partnerships. But besides the existing medical legal partnerships, if you're thinking about creating a medical legal partnership, the National Center, their purpose is also to help provide technical assistance in helping develop these medical legal partnerships. So they actually have toolkits for how you would start it. They have different forms, and oftentimes these partnerships require MOUs, and they even have template MOUs for that. So I would encourage you to look on their site for that.
Thank you. That is really wonderfully helpful. People are excited about the idea. I'm going to ask you to start with this question, Raul, because it kind of follows from what you were talking about with the design elements. I loved the buildings that you showed, and I know we got a lot of comments coming in about how beautiful they are. And what I really loved about this was how they used the design elements to affirm the residents and to honor the residents. That's, it's spectacular. So one of the questions that we've gotten is, have you experienced different engagement levels for women, for female clients than male clients? And, if so, why do you think that is? And how do you engage women? And then, Jack, I think you'll have some information to tack on here as well. So, Raul, if you'd like to start us, that would be spectacular.
I would say yes. I also would say that I'm not an expert in the field, and I would not say that I've been to many parts of the housing programs. But one thing I do know is, and one of the best practices I've seen is to really understand the population. So for example, at the Dolores Project, one of the things they explained to me, especially with the homeless population, is that they get a lot of people who are in prison and jail reentry. So they are coming out of prisons, they're coming out of jail. So this is their first home as they're going to establish themselves. So in So they said the way we engage and make sure that these women can be successful is every Monday morning, people are allowed to call or make a reservation for the whole week so that they can work at McDonald's, they can get off. That's how they engage the women, by saying, we are trying to get back on your feet. Here's a policy in which this is not going to interfere with your work. That's a very different engagement for people who have been out on the streets all day and just coming to the shelter to get a bed. So I really say I don't think it's necessarily gender specific. I think we need to be clear as to who are our customers and what are the best way to engage them.
Thank you. And with women, oftentimes we're dealing with a system. Women often have their children with them, and it's you know, it's a very difficult. It's very difficult, maybe more difficult, to engage a system than it is an individual. So, thank you, Jack. What would you add?
Well, I would just mention that we've done a qualitative study trying to understand how homeless clients define a home, because I think when we think about housing, which is kind of a physical space, we should also think about what a home is. So it's obviously related to the physical space, but what we found in our study was that oftentimes people talked about kind of emotional connection to places and making it their own. So I think while the buildings are obviously very beautiful, I think beyond the physical part of it, the idea of a home, there's an emotional part of it that we have to think about. And of course, it's important in terms of helping people maintain their housing and even care for it, you know, making sure they're up to schedule with their rent, but also that they're keeping it in good order and that they care about the physical space.
If Jack, that's so right. If I may add, I mean, I've heard people use the term housing loneliness. That the housing loneliness sets in.
Yeah,
that's
absolutely
interesting. And we've all seen that. I think someone comes in after an extended period of homelessness, and I've had many people say, you know, I just love Bob, and I am so happy that we were able to get him into housing, but you know, he is still sleeping outside, you know, maybe nearby, or still sleeping on the floor, or you know, and I know one woman who'd been out for a long time said to me, the silence inside that house is deafening. And I thought, that's really interesting. So that makes that point beautifully, Raul. Thank you. So we have another question here. So can you provide an example or guidance to mental health and substance use disorder treatment providers who are reluctant to integrate due to having different clinical philosophies on how to help a Medicaid recipient? Common example, a practitioner who did not view addiction as a chronic medical condition are often resistant to integrating with MAT or medication-assisted treatment programs. In a more extreme example, individuals who receive MAT may be barred from services of one sort or another. So can you guys, this is a hard question, and I'm wondering who would like to tackle it first.
My thought is, I don't have an answer. You know, I mean, it really is, but I think it goes back to what I said. You're addressing the issue around it's our practices and our policies that keep people away, and so you're right. If you're going to co-locate, however, I think the foundation in terms of the many systems I go into, the foundation has to be the values of the system, and really an agreement on the values. We may have different strategies, but it's the values is what needs to be consistent.
Thank you. And I mean, it sounds like it's important. Go ahead.
I was going to say it sounds like an organizational issue. So I think it's important for the leadership of the, I don't know if it's one organization or two different organizations, to figure out, whether they want to align their philosophies. But certainly it can be counterproductive for the clients, especially if, there's differing philosophies and the client, there's potential for splitting or something between providers. And so that could be an issue, but I would think you would want to deal with it on an organizational level, and it would really be the responsible for the leadership to train and determine the direction of the organization and the philosophy.
Mm-hmm.
Absolutely. I think that's exactly right. I know that no wrong door philosophies have swept through, and that's been, one of the great instruments of change in terms of bringing together the systems. But it can often be useful just to have, to bring everybody together in a room to begin talking about how can we work together. So thank you for that. Mm-hmm. Do either of you have any comments on virtual engagement or e-therapeutic engagement? You talked quite a lot about that, Jack, and I think it's particularly in rural areas, this could be an enormously useful strategy.
Yeah, I think telemental health has so much potential. I think the studies I've seen so far really haven't shown any major differences in terms of telemental health versus face-to-face mental health treatment, and so I'm not sure what I get. Obviously some drawbacks with the things I mentioned, access to technology and possible physical or mental barriers to accessing technologies, but it's happening at a large scale. A lot of hospitals are adopting it. In the VA, I forget the goal, but it's a large goal of trying to train all their mental health providers on telemental health. I think it's 50-60%, some metric like that. So it's definitely a large movement.
Thank you. Jack or Raul, do you have anything to add? I don't.
Well, my topic was connections.
Right.
Virtual or any type of connection,
right.
Yeah, is still better than none, right?
Absolutely. So here's a question for you, Raul. So you mentioned a father who lost his job because of child support. Fathers are challenged to get assistance when they are working poor, quote unquote, especially if moms are getting legal help to go to help them get support. So judges add on extra fees rather than settling on a reasonable payment program. Father loses job, mom gets no support, everybody loses, which in that scenario, that is lose-lose. So can you speak to that at all?
The point of my example for that is that if the person who is the caseworker who's looking at the child payments, if they would just talk to, because this is a person from prison reentry, this person is a caseworker, if they will just talk to each other, and I'm using that as the disconnection in our systems, where the people we're trying to engage really become the victims in some ways.
Absolutely. Thank you for that. We've got about 41 seconds left in this segment before we close out. Jack, do you have any final words?
No, it's great to be part of this. I'm available if people want to contact me with further questions.
Thank you. Wonderful. Raul, any last words?
The same. Thank you for having me, and I'll be happy to field questions if people want to email.
Thank you. So in closing, if you'd like to type in one thing that you'll take away from this session, we would find that enormously useful. I'm going to encourage you to choose another session. We'll be coming right up after a half-hour break for another session. And then I would also encourage you to attend the roundtable at the end of the day, where we'll bring several of our experts together to kind of talk about across the day, what did we hear and what did we learn. That one should be a really spectacular conversation. And the next one in this track, we'll be looking at housing access with Ann Denton and Greg Shin, and that should be an excellent session as well in track 1. And this is just a little bit of information about HHRN technical assistance. We do provide Homeless and Housing Resource Network technical assistance and support to federal, state, and local agencies, providers, individuals, and families who experience or are at risk of homelessness. And SAMHSA is enormously responsive and a wonderful agency to hold the reins of this important technical assistance resource. Here is the contact information for Jack Tsai and Raul Almazar. And I'll leave it there for a moment in case you wish to get it. We will make these slides available as well as the recording of the session for your future use. And that concludes this session of the virtual Summit on Homelessness, Serious Mental Illness, and Substance Use Disorders.